Hello everyone. So welcome to the recall of INICET May 2025 and I'm Dr. Ankit. So this time INICET exam was difficult and approximately 25 or 26 questions were asked from pharmacology. So let's discuss. So if you want to have any doubt, if you have any doubt, you can ask me on these respective channels on Instagram, Facebook, Telegram, and this is the link to this YouTube channel. So the first question that was asked was, which of the following statement regarding bempedoic acid are correct? So it's a new drug recently got approved in 2020 by FDA. And let's see what are the options we have. So first question is that it is a non-competitive inhibitor of ATP citrate lyase. Now remember, it is an inhibitor of ATP citrate lyase, but it is not a non-competitive. It is rather a competitive inhibitor of ATP citrate lyase. Now, first statement becomes false. Now, bempedoic acid is used to reduce cholesterol level along with diet and statins. Yes, it's a true statement. The structure or chemical nature is dicarboxylic acid, again a true statement. And it inhibits de novo synthesis of cholesterol inside the body or inside the liver, again a true statement. So can we say the option number A is the only option which is false? So the correct answer for our question is option number B. Now what do you mean by ATP citrate lyase? So just understand how cholesterol is synthesized in the body. Remember, in liver or inside the body we can write de novo. How cholesterol is synthesized? There is a molecule known as ATP citrate lyase. Now this ATP citrate lyase enzyme converts ATP citrate into HMG-CoA, a molecule, and this HMG-CoA finally gets converted into cholesterol with the help of an enzyme HMG-CoA reductase. So this second enzyme, which is HMG-CoA reductase, remember it is the rate limiting step of cholesterol synthesis. This second step, which is HMG-CoA reductase, it is inhibited by a very famous drug we know, statins. Statins, they inhibit HMG-CoA reductase, while bempedoic acid inhibit ATP citrate lyase. So one step before of statin, it is inhibited by bempedoic acid. So keeping this thing in mind, let's see what Goodman and Gilman 14th edition says, that bempedoic acid is a dicarboxylic acid. It's a true statement. It is the option number C we have. It inhibits de novo cholesterol synthesis inside the liver. Again, option number D. Now, it is a competitive inhibitor of ACL, which is a ATP citrate lyase. So, option number A was incorrect, and it is used with statins. It is used in the combination with statins to reduce LDL cholesterol or cholesterol level. So, again, option number B is also correct. Next question is, which of the following statement regarding now thalidomide is correct? So remember, thalidomide is a very repetitive question in INICET exam. So first option is thalidomide is an anti-metabolite. Now this is a false statement. Remember, anti-metabolites are the drugs which inhibit DNA synthesis. So we know for DNA we require folic acid. So folic acid inhibitors like methotrexate, it is an anti-metabolite. DNA also require purines and pyrimidine. So fake purines and fake pyrimidines, they are known as anti-metabolite like 5-fluorouracil, etc. So these drugs are anti-cancer drug which are anti-metabolite. Thalidomide, remember, is a small protein. It is not an anti-metabolite, it is a small protein. And it is used as an immunosuppressant. Now the second part is true. Because it is used as an immunosuppressant, thalidomide is given to reduce excessive immunity or hypersensitivity in type 2 lepra reaction, which is also known as ENL, erythema nodosum leprosum. So the third statement is also true. Now thalidomide is also used in cancers. Yes, it is given in the treatment of multiple myeloma also, because it has anti-cancer property. And we know thalidomide history. The disaster when we used thalidomide some 70-80 years back in a pregnant female, it was causing teratogenic effect like phocomelia. So in fetus, it was causing short limbs, which was known as phocomelia. So can we say again the option number A, it is the only false statement. B, C and D, they are the true statement. So the correct answer, we have to find correct answer are B, C and D, they are correct answer. Now next question is match the following drug with the respective corresponding schedules under Drug and Cosmetic Act. Remember, Drug and Cosmetic Act is the law which regulate the sale, purchase and manufacturing of the drug. Now we know that certain drugs are dangerous to use, they are addictive drugs. So we classify them in the different schedule. So we have different schedule like H, Z, X and G. So first let's understand what are the different schedule. The first we have is schedule G. Under schedule G, we give those drugs which are given, G for given, under medical supervision. That means these drugs must be given in front of a doctor. Patient cannot take a drug at home. So they are given only under medical supervision. Can we write the classical example? Vaccines. Vaccines patient should not take at home. A doctor or a medical practitioner only gives vaccine to the patient. So schedule G contains vaccine. Then we have schedule Z. Z for zebra we can remember. So these drugs are those drugs which are used in animals, or animals used drugs are known as veterinary drugs. So veterinary drugs, they come under Z, schedule Z. Then we have schedule X. X is the most dangerous letter, and dangerous means that these drugs are narcotic and psychotropic drug. That means these drugs have addictive potential and person may start abusing these drugs. So can you recall certain addictive drug, like opioids, like morphine? And previous year, instead of morphine, ketamine was asked. And lastly, we have schedule H drug. H are prescription drug. Prescription drug means these drugs are only given by chemist when you will show a written prescription of a doctor. And can we say insulin should be a prescription drug? Yes. So insulin patient can take. Is insulin narcotic or addictive? No, insulin is not addictive. Patient can take insulin at home. So that is why insulin will not also come under schedule G. So keeping this thing in mind, now let's try to answer this question again. So schedule H, remember prescription drug, insulin comes under schedule H. Agreed? So H1. Z for zebra, veterinary drug. X means addictive drug, morphine, and G means the drug which are given under medical supervision like vaccines. So the answer of our question comes out to be option number A. Now the fourth question is, a male patient with purulent discharge from penis. So that means the patient must be having some sexually transmitted infection or STD. Now microscopy reveals gram-negative diplococci. So which gram-negative bacteria do you think can cause STD? Yes, it is Neisseria gonorrhea. Neisseria gonorrhea. So this patient is suffering from gonorrhea. Now resistant testing was done and the patient was found to be penicillin resistant. Now remember in earlier time, the treatment of Neisseria gonorrhea was penicillin G. It was penicillin G, but now there is penicillin resistance. Now why there is penicillin resistance? Because this Neisseria gonorrhea, it started producing one enzyme known as penicillinase enzyme. Can we call this bacteria as penicillinase producing Neisseria gonorrhea? So this enzyme produced by N. gonorrhea, it degrades penicillin G. So because of this reason, now in penicillin resistant cases, now the drug of choice is ceftriaxone. Now the drug of choice is ceftriaxone. So go with the correct answer now is ceftriaxone. So amoxicillin is a type of penicillin only because it is ending with the word cillin. So it will be degraded inside gonorrhea. So amoxicillin is not the correct answer. Tetracycline, no, we don't give. Tetracycline is rather given for another sexually transmitted infection, that is chlamydia. Remember, tetracyclines are not effective in gonorrhea. They are rather given in chlamydia, another STD which causes LGV, lymphogranuloma venerum. And vancomycin is never effective against any gram-negative infection. Any gram-negative bacteria, vancomycin is not effective because vancomycin is only a drug for gram-positive infection like Staphylococcus, MRSA. Agreed? Now, nowadays, we are even finding resistance against ceftriaxone. So this is one additional point I am telling you. Remember, in any ceftriaxone resistant cases, we give carbapenems. Carbapenems like meropenem, imipenem, they are given in resistant cases of cephalosporins like ceftriaxone. Now, how we can remember it? Remember, any gram negative infection, any gram negative bacteria which spreads in community easily, that means it's a community acquired infection, we always give ceftriaxone. We always give ceftriaxone. So can you recall any other gram negative infection which spreads in community apart from gonorrhea? Can we say typhoid, meningococci, H influenza? Everywhere the drug of choice is ceftriaxone. But if this gram negative infection, it causes infection in hospital, whether we can we write it as hospital acquired infection? In hospital acquired infection, we give carbapenems like meropenem. Because in hospital acquired bacteria, these bacteria are resistant to commonly used antibiotics like ceftriaxone and penicillin. So here we directly start with meropenem, which is a carbapenem group of antibiotics. So this is a trick you can remember to answer any question. Now the next question is, which of the following is the most appropriate treatment in a diabetic person with complicated urinary tract infection presenting with septic shock? Now remember, the most common cause of complicated UTI is, so complicated UTI means there is urinary tract infection, kidney, ureter, bladder infection, plus there is some associated features like shock, sepsis, etc. We start with beta-lactam group of antibiotics. So in beta-lactam group of antibiotic, remember we have penicillins like amoxicillin, we have piperacillin, we have cephalosporins like ceftriaxone, and we have carbapenems like meropenem. This part we have discussed in regular lecture. Now let's understand what are the main common causes of complicated UTI. Complicated UTI is mainly caused by gram-negative infection. Gram-negative bacteria. Again, we are writing gram-negative. So the most common cause of complicated UTI is E. coli. 70% cases are caused by E. coli. Apart from E. coli, Pseudomonas is a very important infection, and especially hospital acquired, and Pseudomonas occurs in diabetic people also. And a very important bacteria, very difficult to kill, is Klebsiella. Klebsiella. Now the point is, if you talk about amoxicillin and ceftriaxone, they are only effective against E. coli. They are only effective against E. coli. Remember, these drugs are not effective against other gram-negative bacteria like Pseudomonas, Klebsiella. Let me write one more bacteria for you, Proteus also. They are not effective. So if other bacteria comes, then the best answer is meropenem. So meropenem, which is a carbapenem group of antibiotic, it is effective against all bacteria and it is the first drug to be started in complicated UTI because it will cover all bacteria. So answer of this question comes out to be meropenem. Fine. So why ampicillin is not the correct answer? Amoxicillin is not the correct answer because it will not cover all bacteria. Same reason with ceftriaxone. Now why nitrofurantoin is not given? Remember, nitrofurantoin is not given in complicated UTI. It is not given in complicated UTI. It is only given in uncomplicated UTI when the patient is not having any sepsis, any shock, etc. So here the best answer is meropenem. Next question, which of the following anti-malarial drugs are commonly used in clinical treatment of malaria? So beta, in clinical treatment of malaria, we have discussed malaria in our country is mainly caused by either P. falciparum or P. vivax and ovale. Now, if you talk about clinical cure or clinical treatment, that means you have to produce symptomatic improvement. In cases of P. falciparum, we give ACT, artemisinin based combination therapy, while in P. vivax and ovale, we give chloroquine. So why we are not giving chloroquine in P. falciparum? Because P. falciparum is resistant to chloroquine. Now ACT is artemisinin based combination therapy, and in all states of India except the northeastern state, we give artesunate with sulfadoxine pyrimethamine combination. Sulfadoxine pyrimethamine combination. Now, what about radical cure and gametocidal drug? Now, what are all these word means? I will tell you. So, radical cure means we have to kill the stage of this plasmodia in liver. So, for radical cure, we give primaquine. We give primaquine. And we don't have to give radical cure in cases of P. falciparum because P. falciparum does not have any latent stage in liver. And as a gametocidal drug, in all cases, we have to give primaquine again. So primaquine is given in all types of malaria, all radical cure, gametocidal, except clinical cure. So can we say artemisinin is given for clinical cure? Sulfadoxine pyrimethamine and chloroquine. So the answer of our question, which is not used, is primaquine is not given in clinical treatment. So the answer of our question comes out to be ABC. So let me make you understand this thing even better. So how malaria spread? Malaria spread through bite of female Anopheline mosquito. And when this mosquito comes, the infective stage to human is sporozoid. Remember, we don't have any drug to kill sporozoid, although we have vaccines which can make antibody against sporozoid. Now, this malaria comes into the liver, and from liver, this stage is known as hepatic schizogony. It goes into the liver. This is known as hepatic schizogony. From liver, it comes into RBC. We call it as erythrocytic schizogony. And remember, now when malaria parasite or plasmodia ruptures RBC, then clinical symptoms come. Now, some of this malaria, they can go back into the mosquito, but remember, in mosquito, only gametes which are present in the blood, they can infect mosquito. Now, this is the cycle of P. falciparum. This is the cycle of P. falciparum. But in cases of P. vivax and ovale, in cases of P. vivax and ovale only, some of this hepatic schizont, they become dormant. They go into sleep. When they go into sleep, this is known as hypnozoid. Agreed? Now let's see how to treat malaria. Now we don't have any drug to kill sporozoid, but yes, we have vaccine which can make antibody against sporozoid so that humans are not infected with malaria. That vaccine name is Mosquiric. Now the drug which will kill hepatic schizogony is primaquine. Agreed? A drug which kill erythrocytic shygogony, all drugs like ACT, chloroquine, except primaquine. The drug which kill gametocyte, so that this will not infect mosquito and this will not infect any other human from that mosquito to prevent transmission of malaria, again primaquine. And the drug that will kill hypnozoitis, again primaquine. So can we say primaquine is used everywhere except erythrocytic shygogony? Now killing erythrocytic shygogony, this is known as clinical cure. This is known as clinical cure. So in clinical cure, all drugs are used except primaquine. When you kill hypnozoid, this is known as radical cure. So again, for radical cure in P. vivax underweil, we give primaquine. And when you want to kill gamete to inhibit transmission of malaria from this mosquito to other people, we call it as, again we give primaquine. And when you kill hepatic shygogony, this is known as causal prophylaxis. So all these things I have explained you in regular lecture. So remember, in clinical cure, primaquine is not used. So next question is, a patient develops ataxia, nystagmus, diplopia. So can you tell me which part of the brain, when becomes damaged, it can lead to imbalance like symptom? The body coordination is lost. There is incoordination like ataxia, nystagmus in eyes, diplopia, है ना? The answer is cerebellar toxicity. It is because of cerebellar toxicity these symptoms come. And the drug which causes cerebellar toxicity is carbamazepine. Carbamazepine is an anti-epileptic drug, causes cerebellar toxicity. Now this patient is also taking erythromycin. What is the most likely cause? Remember, carbamazepine directly causes cerebellar toxicity by damaging brain. And this carbamazepine normally, it becomes degraded. It becomes degraded by which enzyme? CYP3A4 enzyme. Now remember, this erythromycin, it inhibits CYP3A4 enzyme. Erythromycin is an inhibitor of CYP enzyme. So if CYP enzymes are not working, can we say the level of carbamazepine will increase further? And it will enhance or increase the risk of cerebellar toxicity. So can you tell me, is it the toxicity of carbamazepine or is it the toxicity of erythromycin which is producing this symptom? Yes, the answer is carbamazepine toxicity. It is not erythromycin toxicity. Okay, worsening of underlying disease is not given. Separate unrelated neurological condition, no. So answer is carbamazepine toxicity. So what is the mechanism of action of phenol-dapam? Now the answer is very simple. If you see this word phenol-dapam, even if you are reading this drug name for the first time, you can answer this. So you can see phenol-dopam, it is ending with the word dopam. So that means it is somewhat related to dopamine. It is somewhat related to dopamine. Dopam word is coming. F for it acts on first dopamine first receptor, D1 receptor, and it stimulates dopamine 1 receptor. It is a dopamine 1 agonist. Now beta, where dopamine 1 receptors are present? Dopamine 1 receptors are present in kidney. It is present in kidney, and in kidney it produces vasodilation. Because it produces vasodilation, blood supply to the kidney will increase. And if blood supply to the kidney will increase, can we say it will increase GFR, glomerular filtration rate? So that is why phenol-dapam, it is given to increase GFR. Now in which condition would you like to increase GFR? When the GFR is low. When the GFR is low, this condition is known as ARF, acute renal failure. So phenol-dapam is given in the treatment of acute renal failure. So the correct answer is option number A. It is a dopamine 1 receptor agonist which is given to increase GFR in cases of acute renal failure. Now, which of the following is the most appropriate treatment of scabies in infant? So let's talk about scabies. What drugs we have? So scabies, we know it is caused by an ectoparasite, Sarcoptes scabi. It spreads very easily. Now, the overall drug of choice for scabies is permethrin. Permethrin. And it is available as 5% cream or lotion. It is the overall drug of choice. It is even the drug of choice for lice. Apart from this, other drugs in scabies are crotameton, benzyl benzoate, ivermectin, and lastly, benzene hexachloride. Benzene hexachloride. So these are the list of the drugs I have given you. Now before coming to the R question, can you tell me the only drug which is given orally for scabies? The only drug which is oral for scabies is ivermectin. Rest all other drugs are given as cream or lotion. Now among them, the first two drugs, permethrin and crotameton, they are safe in children and pregnancy. Fine. While the last three drugs, they are absolutely contraindicated in children and pregnancy. Why? Because if they are given in children, especially less than 5 years of age, and pregnancy, they will go to the fetus and they can enter into the brain, and in brain they can produce convulsions or seizures. Now this is a more dangerous thing than scabies. So that is why they are not given in pregnancy and children. So can you tell me the answer of this question now? Yes. So permethrin can be given in infant, crotameton is given, ivermectin and benzyl benzoate are not given. So the answer of our question comes out to be option A and B only. So next question is, which of the following factors are involved in calculating loading dose of a drug? So first let me tell you what are the formulas of loading dose and maintenance dose. So loading dose is the first dose we give in our patient to achieve target concentration. So loading dose we calculate as IV loading dose is calculated as volume of distribution into the target concentration which you want to achieve in plasma. Target plasma concentration. Agreed? Now, after you have achieved target plasma concentration, now you want to maintain this concentration in your patient. Then we give maintenance dose, and maintenance dose depends upon the clearance capacity. CL means clearance capacity into target plasma concentration. Now I have already given you the trick how to remember loading. D word is coming in loading. So always remember D word is coming, that is volume of distribution. In maintenance, C word is coming, it is the clearance capacity. Now remember they are IV route, they are given by IV route. So if you want to calculate oral or any other route, you have to divide this whole formula with bioavailability, which symbol is F. So if you want to calculate an oral or any other route, you have to divide the whole formula with bioavailability. So can you tell me now three factors on which loading dose depends upon? Volume of distribution, target plasma concentration, and bioavailability. So keeping this thing in mind, now we can answer our question very easily. So it depends upon volume of distribution, target plasma concentration, and bioavailability. So it does not depend upon half-life, no relation with half-life. So option number A, B, C is the correct answer. So next question, which of the following drug, it's a new question. Although we have discussed in contraceptive chapter as well, but it was asked first time in INICET. So which of the following drug is known to cause cholestasis? That means obstruction of bile ducts in liver, without any producing portal inflammation. Now, why they have asked you this question? The reason is very simple. There is a table given in Harrison on page number 2586. And this question came directly from this table. So let's see. The first molecule which can damage liver by direct toxic effect is carbon tetrachloride. It can produce necrosis and fatty inflammation, fatty infiltration. This is not asked. Second is acetaminophen, which is paracetamol. So we have discussed that paracetamol causes centrilobular necrosis. Then we have amoxicillin clavulanic acid. It can lead to mixed hepatocellular cholestasis. Then we have TB drug which causes liver damage, isoniazid. It causes hepatocellular injury resembling viral hepatitis. And the last one is oral contraceptive pills or any hormonal preparation like estrogen, progesterone and testosterone. They can lead to cholestasis without portal inflammation. They can lead to cholestasis without portal inflammation. So now let's see, all these options were given. You can see all these options are given. Same table, same option. So a direct question from Harrison. So acetaminophen, no. Amoxicillin clavulanic acid, no. Isoniazid, no. So the answer is hormonal preparation, estrogens and androgens. So now the next question is, which of the following is a new psychoactive drug, works as rapidly acting antidepressant? So we have discussed a new antidepressant drug which has been approved is ketamine. Okay. So cannabinoid are not antidepressant, but yes, they are recently been approved as anti-epileptic. Okay. Now bupropion is an antidepressant. Yes. But remember, it is not a psychoactive drug and it is not a rapidly acting drug. If you give bupropion today, its action will come after 4 to 6 weeks. So answer here is ketamine. Remember, ketamine is a psychoactive drug. That is why people abuse it. It is known as angel dust, PCP, many. It is also misused as a date rape drug. Now, but this ketamine, it is used as a general anesthetic, but nowadays it has been approved as antidepressant also. Now, this ketamine, when given IV, it is a very rapidly acting antidepressant. It is given to reduce depression in ICU or IPD patient when you have admitted the patient. Now this ketamine, it is also nowadays available as a nasal spray. And this nasal spray of ketamine comes with an enantiomer S-ketamine. And it can be used in OPD patient. Patient can take at home. And IV ketamine can be given in inpatient, the patient which has been admitted. So next question we have is, which of the following drug is used to reverse the effect of vicuronium and atracurium? So I have told you, any drug that ends with the word curare, curium and curonium, they are non-depolarizing muscle relaxant. Non-depolarizing muscle relaxant, they block acetylcholine NM receptor. They block NM receptor of acetylcholine. Remember, NM receptor of acetylcholine causes muscle contraction by depolarizing muscle. So if you block them with curare, curonium and curonium, these drugs will inhibit depolarization, non-depolarizing, and the muscles will become relaxed. Now, to reverse the effect, so these muscle relaxants are given during surgery. Now surgery is over. We want the patient should move again. To reverse the effect, the drug of choice is neostigmine. You can also use, apart from neostigmine, you can also use idrophonium. Why? Because these drugs, they increase the level of acetylcholine in the body. And this acetylcholine will overcome the blockage of NM receptor. So the reversal agent for muscle relaxant is always neostigmine. Now remember why dantrolene is not the correct answer. Dantrolene itself is a muscle relaxant given in the treatment of malignant hyperthermia. Baclofen itself is a muscle relaxant given in cerebral palsy, sprain and etc. Ectropin rather blocks muscarinic receptor of acetylcholine. It has no relation with NM receptor. Next question we have is, what is the drug interaction between imipramine and diphenhydramine? So first of all, understand in which class these drugs they come. Imipramine, remember, it is a TCA, tricyclic antidepressant. And diphenhydramine, which comes with the brand name Benadryl, it is an antihistaminic drug. It is the first generation antihistaminic drug which enters into brain as well. And I have told you, tricyclic antidepressant, antihistaminic drug, they are non-specific drug. This classes of drug, they also have anticholinergic action. These drugs, they have anticholinergic action like ectropin. That means they block muscarinic receptor of acetylcholine, which can lead to ectropin-like effect. So, what is the answer? So, if you combine these drugs together, they both block muscarinic receptor. And similar toxicity of ectropin-like toxicity comes. Next question, erythropoietin is used in the treatment of which type of anemia? Now remember, erythropoietin, it is produced by kidney. Kidney produce erythropoietin. And this erythropoietin, it goes into the bone marrow. Suppose this is the bone marrow. And in bone marrow, these stem cells on which erythropoietin receptors are there, and these stem cell receptors, they are stimulated and they divide and they increase RBC production. This is what the action of erythropoietin is. So the first use of erythropoietin is when kidney is not producing erythropoietin, there is erythropoietin deficiency. Can we say there will be anemia? So erythropoietin is given in the treatment of anemia due to chronic kidney disease. Fine. Now let's see why not other option. Then we have aplastic anemia. Remember, in aplastic anemia, stem cells are dead. The bone marrow is hypocellular. There is dry tap. Stem cells are not working. Do you think if we give erythropoietin from outside, will stem cells divide? No, stem cells are dead. So it cannot be given in the treatment of aplastic anemia. So in aplastic anemia, we have to do bone marrow transplantation. Agreed? Nutritional anemia. Remember, in nutritional anemia, stem cells are fine. But nutritional anemia is because of deficiency of iron, folic acid, vitamin B12, etc. Now remember, we have to replace nutrient. If we will give erythropoietin will not able to produce RBC because the molecules which are required to produce RBC inside the stem cells are lacking. So it is never given in nutritional anemia. Lastly, myelofibrosis. So myelofibrosis, it is an autoimmune disease in which antibodies are produced which damage your stem cells. Although erythropoietin level is normal in the body. So in myelofibrosis, we have to remove antibodies. So we have to give glucocorticoid, immunosuppressive drug in myelofibrosis. So the only use of erythropoietin in this option is option number C. Other, no use. Then we have next question. A young boy presented with platelet count of 10,000. So it is very less platelet count. Normal platelet count should be more than 1.5 lakh. Now a bone marrow aspirate shows normal cellularity with increased number of megakaryocyte or the stem cells which can make your platelet. What is the most appropriate treatment? Remember, this is a typical case of ITP. ITP stands for idiopathic thrombocytopenic purpura. So beta, what happens in ITP? The bone marrow is absolutely normal. The bone marrow is absolutely normal. That means the megakaryocytes are absolutely normal inside the bone marrow. This is what is given in the question. Now these are the platelets which are present in blood. In blood we have platelets. Antibodies are produced against this platelet. And these platelets are destroyed inside the blood. So this is ITP, which is an autoimmune disease in which antibodies are produced against platelet, which leads to thrombocytopenia. So what is the treatment? Don't you think we have to remove these antibodies? So let's understand what is the treatment of idiopathic thrombocytopenic purpura. So let me show you a slide of ITP. Just a second. So let me show you a slide how to treat ITP. We will understand with pathology. So suppose this is a platelet. So in ITP, it is an autoimmune disease. Let's say antibodies are produced against platelet. So these antibodies are produced against platelet. Now these antibodies, they go to macrophages. They go to macrophages. And on macrophages, there is a receptor known as FYC receptor. Try to remember the name FYC. So this FYC receptor, it binds to this antibodies and now they will destroy platelet. Now where these macrophages are present? These macrophages or reticuloendothelial cells, they are present in spleen. That is why spleen slowly and slowly becomes enlarged and it can lead to splenomegaly in ITP. So let's see how to treat. Don't you think we have to reduce antibody production? So the drug which is given to reduce antibody production is glucocorticoids like prednisolone. So we give prednisolone like drug for initial treatment induction because they very fast reduce antibody production, and then we maintain the patient on azathioprine because long-term administration of glucocorticoid, it can lead to Cushing syndrome. So we maintain the patient on azathioprine. More than 80% of the people, they get treated with this simple treatment. Now there is a new drug which inhibit the action of macrophages, which was recently asked in INICET. The drug name is fosgamitinib. Fosgamitinib. Fosgamitinib, F for it inhibit which receptor? It inhibit FYC receptor on macrophages. And remember, this FYC receptor is a type of tyrosine kinase receptor. And I have told you any drug which ends with the word tinib is a tyrosine kinase, T for tyrosine kinase. Inhib means inhibitor, like imatinib, erlotinib, fosgamitinib. So it's a new drug approved for ITP, idiopathic thrombocytopenic purpura. Now we have drug which can increase platelet count. The drug which have been approved to increase platelet count is romiplastim. Again, it has been asked in INICET. So how we can remember? Plastim. It is a platelet stimulator. And we have a drug L-trombopag. How we can remember L-trombopag? You can see trombo word is coming and Ag word is coming. It is a thrombopoietin agonist. Thrombopoietin increased platelet count. Now, if the patient is still not getting improved by all these therapies, we call it as refractory ITP. So don't you think in refractory ITP, we have to remove this antibody? The drug which can remove or kill this antibody is IVIG, intravenous immunoglobulin, and we can give along with the drug rituximab. Rituximab will also reduce antibody production. Or there is a role of a surgery. Can you tell me which organ we can remove? We can remove splenectomy. So this is the treatment of ITP. So in simple word, now let's talk about what is the answer of our question. Let's come back to our slide. What is the answer? Now you can answer this question very easily. So can you tell me which of the following option can be given in the treatment of ITP? Yes, it is intravenous immunoglobulin, which will remove this autoantibodies. So next question is, which of the following are the side effect of topical corticosteroid use? So topical corticosteroid, their most common side effect is skin atrophy because they damage collagen. They damage collagen protein. Now, don't you think steroids, they reduce immunity? which can lead to infection. Infection can lead to acne. So they can cause acneiform eruption. Now, certain corticosteroids, they can cause excessive hair growth. They can cause hypertrichosis as well. Now, what about blue pigmentation? Blue pigmentation of skin. It is mainly a side effect of one antiarrhythmic drug, amiodarone. Okay, so blue pigmentation is not seen. So the answer of our question is ABC. Next question, which of the following drug can be used in acute mania episode, during acute attack of mania? So the drug which can be given as in acute attack of mania are three. Val. First drug which we can give is valproate, the most effective drug. We can also give antipsychotic drugs like clozapine, olanzapine, etc. And a very famous drug is lithium. And that is why these drugs are most commonly used drug for mania or bipolar disorder. So antipsychotic, you can write one more drug. Haloperidol is also an antipsychotic because it is given in our option. So we can give. So remember, the answer of this question is amitriptyline is not used. So option number A, B and C, they can be used. Amitriptyline, remember, they are antidepressant drug. It is under which class? Antidepressant. It's a tricyclic antidepressant. Remember, antidepressant drugs are absolutely contraindicated in mania because they increase the risk of mania. They increase the risk of mania. Let's understand. So if you talk about your mood, suppose this is the normal mood of a person. This is the normal mood of a person. When the mood becomes excessively elated or high, we call it as mania. And when the mood becomes very less, it is known as depression. It is known as depression. Now remember, if you will give antidepressant drug, AD, what will happen? They will improve depression, and they can increase the risk of mania. That is why in maniac episode, never give antidepressants like amitriptyline. They will improve the mood excessively. It can lead to mania. A 70-year-old male patient with hypertension, type 2 diabetes mellitus, presented with progressive shortness of breath, bilateral pedal edema. So these symptoms are the symptoms of heart failure. Now echocardiography revealed left ventricular hypertrophy and left ventricular ejection fraction is 50. Remember, the normal ejection fraction is always more than 50. So here it is 60. So can we say heart is failing, but ejection fraction or the blood which is pumped by the heart is normal? Can we call this stage is known as heart failure with preserved ejection fraction? This disease is known as heart failure with preserved ejection fraction. If ejection fraction is less than 50, we call it as heart failure with reduced ejection fraction. What is the management? Remember, we have to protect heart because the heart is failing. And the drug which is given is SGLT2 inhibitor with loop diuretic. Remember, these drugs like digoxin, dopamine, they are contraindicated in heart failure with preserved ejection fraction. These drugs are inotropic drug. They are only and only given to increase cardiac output. So these drugs are only given when there is heart failure with reduced ejection fraction. They are never given in preserved ejection fraction. So let's see what is the treatment of heart failure with preserved ejection fraction. Now, to control edema and dyspnea because of pulmonary edema, we give diuretic. And among diuretic, we start with loop diuretics. So why we give loop diuretics? To treat pedal edema, bilateral pedal edema. And if blood is collected in lungs, we call it as pulmonary edema, which leads to shortness of breath and dyspnea. We give diuretic, the first drug to be started. After you have started diuretic, then we will start cardioprotective drugs, the drugs which can protect the damage of the heart. And very few drugs are cardioprotective drug. First class of drug we always start is SGLT2 inhibitor. These drugs are also given in diabetes mellitus. They end with the word gliflozin. Can you tell me any famous gliflozin in the comment section, which are used in diabetes, also given in heart failure? So please write in comment section gliflozin like drug. So that is a question for you. After gliflozin, still the heart is getting damage. Echocardiography is releasing damage of the heart. We start ARNI. ARNI stand for angiotensin receptor and neprilysin inhibitor. So there is a drug known as neprilysin inhibitor, sacubitril, given with angiotensin receptor blocker, valsartan. This combination we give. Still not controlled, we add third drug, cardioprotective MRA. MRA is mineralocorticoid receptor antagonist. Mineralocorticoid receptor antagonist. Just a second. So a very famous drug we all know among mineralocorticoid receptor antagonists is spironolactone. So it blocks aldosterone or mineralocorticoid receptor, which damages heart. Still not controlled. Lastly, we add, because the evidence is very less, we give ARB. ARB is angiotensin receptor blocker. These drugs also end with the word sartan, like telmisartan, valsartan, etc. So this is the management of heart failure with preserved ejection fraction. Now find the incorrect or false statement. Now, cannabinoids like bhang, charas, ganja, they produce withdrawal effect. Obviously, they produce withdrawal effect. Any drug of abuse, when you are not taking, will lead to withdrawal effect. Opioids withdrawal can be fatal. Yes, a patient can go into scissors. Patient can go into shock in opioid withdrawal. Now, alcohol withdrawal is treated with flumazenil. Now, this is a false. Flumazenil, remember, it is an antidote of benzodiazepine toxicity, like diazepam, lorazepam toxicity. Remember, alcohol withdrawal is treated with benzodiazepine. We treat alcohol withdrawal with benzodiazepine, like diazepam and lorazepam. So it is not treated with flumazenil. It will rather precipitate alcohol withdrawal. So option C is a false statement. Buprenorphine is given in opioid withdrawal. Yes, we have discussed three drugs, buprenorphine, methadone and tramadol, given for opioid withdrawal. So C is the false statement. Now, a male patient presented with painful red vesicles on genital region from past 2 weeks. Histopathology on Zank smear shows this image. So we can see big multinucleated giant cell. So it is multinucleated giant cells. Okay, these are the big giant cells. So can you tell me which infection we are talking about? Yes, we are talking about herpes simplex virus infection. It can lead to painful red vesicle, which you commonly call it as buboes, inguinal bubo. So which drug we give? It's a viral infection. The drug of choice for herpes simplex virus is acyclovir. So acyclovir is the drug of choice. Next question. Gonadotropin releasing hormone receptor antagonist. These drugs, they end with the word relics, like cetorelix, ganirelix. Remember, when you block gonadotropin releasing hormone receptor on pituitary, so suppose this is hypothalamus. Hypothalamus produces GnRH and it acts on pituitary, and pituitary produces FSH and LH hormone, which increases fertility, estrogen and testosterone production. So these drugs, they block GnRH receptors. And can we say cetorelix, ganirelix, they decrease FSH and LH hormone production from pituitary? Can we say it will further reduce estrogen production, testosterone production later on with FSH and LH levels are reduced? So they are useful in all indication except. So prostate cancer, yes, they are given. Why? Because by reducing FSH and LH, they will decrease testosterone production. Prostate cancer is a testosterone dependent cancer. So it is given for ovarian cyst, yes, because it will decrease estrogen and progesterone production, which can lead to ovarian cyst, especially in PCOD. They are given for IVF. Yes, they can be given for IVF. Why? Because in IVF or controlled ovarian hyperstimulation, we reduce the production of endogenous FSH and LH hormone. Then we give FSH and LH from outside. Because we can produce controlled ovarian hyperstimulation, we tell our ovaries to produce ova when we give the drug. So during that time, we give this relics like drug. Now remember, they are not given in hypogonadotropic hypogonadism in male. Now this disease occurs because of deficiency of GnRH. If already there is deficiency, the person or the male is suffering from infertility. Would you like to further reduce GnRH? No. Here in the treatment of hypogonadism, we give the treatment with GnRH hormone from outside. Like, so many drugs like histrelin, nafarelin, these drugs are given for the treatment of GnRH for the treatment of hypogonadotropic hypogonadism in male. Now, which drug is not used for controlling PPH, postpartum hemorrhage? Now, let's understand. Suppose this is uterus and this is the upper segment of the uterus, this is the lower segment of the uterus. Now, why postpartum hemorrhage happens? After the child is delivered, the blood vessels in uterus, they are bleeding. And it is leading to PPH, postpartum hemorrhage. That is why to control postpartum hemorrhage, we contract the uterus. So we contract the upper segment of uterus. Because if we will contract the muscle, these blood vessels will become crunched or blocked between the muscles and the bleeding will stop. Now, which drug we give? The overall drug of choice is oxytocin. Oxytocin is given. IV, it is considered to be the drug of choice to control PPH. In oxytocin resistant cases, we can give prostaglandin, F2 alpha. It will also contract upper segment or muscles of the uterus like carboprost. And the second option we can give in oxytocin resistant cases is ergometrin or methylergometrin, which comes with the brand name Methergin. You can also give misoprostol. And remember, misoprostol is PGE1. Now, all these drugs are given by injection. Because if you will give a drug by injection, it will go to the uterus and contract. Now, the answer of our question is dinoprostone. Dinoprostone is not used. Dinoprostone is prostaglandin E2. Now, why it is not used? The first reason is dinoprost is not available IV. It is not available IV. It is only given as a cervical or vaginal cream. Now, when it is given as a cervical or vaginal cream, this dinoprostone, remember, it will only go to the lower segment of uterus. Dinoprostone only goes to the lower segment of the uterus and it will dilate lower segment of the uterus. That is why dinoprostone is rather considered as a drug of choice for cervical dilation, which is also known as cervical ripening. We rather used in cervical ripening because it is only available as a vaginal cream. So now the next question is, an adult male with a blood pressure of 146 by 94 and 158 by 92 recorded at an interval of 30 minutes. No comorbidity. Next step in management. Now remember, if the blood pressure is more than 130 by 80, we call the patient as hypertensive. Fine. And the patient is having no comorbidity, then we call it as essential hypertension. And there are 3 first-line drugs which are approved for essential hypertension are CAT. One is calcium channel blocker, DHP type. These drugs, they end with the word dipine, like amlodipine, clinidipine, nifedipine. We can give ACE inhibitor, which will end with the word pril, or angiotensin receptor blocker, which will end with the word sartan, or we can give thiazides. So these are the 3 drugs we can start. Now let's see all options. Now the person is saying admit the patient and give IV antihypertensive. False. Remember, IV hypertensives, they are only given in emergency scenario. We only give in hypertensive emergency, and hypertensive emergency means when the blood pressure is more than 180 by 120. Here the BP is not beyond 180. Refer to higher center? No. Remember, we can treat hypertension in PHC or a lower center also, because we have to simply give an oral drug. No need to intervention? False. Remember, the BP is high. We have to give intervention. So the best answer for our question is start amlodipine and do regular follow-up, because amlodipine is a calcium channel blocker, DHP type. So D is the correct answer. So let's talk about the last question, an easy one. Which anti-epileptic drug causes neural tube defect like spina bifida in pregnancy in a female who is planning to conceive? So we have already discussed the most teratogenic anti-epileptic drug which should never be started in pregnancy is valproate, because valproate can lead to folic acid deficiency, and folic acid deficiency can lead to neural tube defect like spina bifida, neural tube defect. Overall, valproate is the most teratogenic anti-epileptic drug. It should never be started in pregnancy. Yes, the safest anti-epileptic drug is levetiracetam. Next safer is lamotrigine, and the third safer most is carbamazepine. Valproate is the most teratogenic. So this is all about INICET recall. I hope you have understood all concept. If you have any doubt, you can ask me on these respective methods on Instagram, Facebook channel, Telegram group, or this YouTube channel. Thank you very much. Best wishes. Keep learning always. Goodbye.